Acute hemolytic anemia secondary to paroxysmal cold hemoglobinuria. Paroxysmal cold hemoglobinuria, or PCH, is an acquired hemolytic anemia caused by IgG antibodies that sensitize RBC at cold temperatures by fixing complement to the RBCs, causing intravascular hemolysis on rewarming. PCH usually appears in young children as recurrent high fevers, chills, and passage of red-brown urine. In the past, PCH was primarily a disease that afflicted patients with secondary or tertiary syphilis. Now, acute PCH occurs most frequently in young children after viral illnesses such as mumps, measles, chickenpox, Epstein-Barr virus, cytomegalovirus, influenza, parvovirus B19, coccivirus A9, and adenovirus. Clinical presentation. A 23-month-old girl, previously healthy according to her parents, arrived at a hospital with an upper respiratory tract infection, decreased activity and appetite, and jaundice. Urinalysis results revealed a trace of blood with 0 to 5 RBCs. 3 weeks before her arrival at the hospital, she experienced intermittent URIs and recent otitis media, treated with antibiotics. Laboratory tests. The initial laboratory findings included a hemoglobin of 5.5, which rapidly decreased to 3.2, and reticulocytopenia with a corrected count of 1.3%. Her peripheral blood smear showed approximately 40% spherocytes, no blasts, no neutrophils, and a normal white blood cell and platelet morphologic characteristics. She had elevated LDH and elevated bilirubin levels. The results of Mycoplasma and Bartonella serologic tests, along with blood and stool cultures, were all negative. Serologic investigation undertaken by the transfusion services at two independent hospitals yielded a negative DAT result and variable reactive antibody screening results. The attending physician consulted the Indiana Blood Center Immunohematology Reference Laboratory, or IRL. Additional requests for a Donat-Landsteiner test should be performed because the antibody was apparent only at lower temperatures, coupled with a low titer and a clinical course that was suspicious for PCH. A fresh serum specimen was obtained from the patient, collecting it in 2 serum tubes and kept it between 24 degrees Celsius and 37 degrees Celsius in a warm water bath to assure that there would be no in vitro binding of the antibody. The specimen was allowed to settle without centrifugation for 2 hours. Then, the serum was collected and sent to the IRL for analysis. Test results. The rec agglutination test polyclonal is 3+, IgG is 0, C3b is 4+. In 3-cell antibody screen, the screening cells 1 to 3 is in immediate spin is 0, patient cells in immediate spin is 2+, screening cells in room temp is weak positive, patient cells in room temp is 2+, screening cells in 15 degrees Celsius is 2+, patient cells in 15 degrees Celsius is 2+, screening cells at 37 degrees Celsius is 0, patient cells in 37 degrees Celsius is 0. In cold autotiter test, in immediate spin, it is 2, 15 degrees Celsius 2, 4 degrees Celsius 4. The Donat-Landsteiner test gives a positive result. During her hospital stay, the patient received transfusion of 2 units of leukoreduced RBCs and azithromycin in case of Mycoplasma infection. She was discharged 5 days after admission in stable condition. A month after discharge, her baseline health had returned to normal, and her hemoglobin count was 14.0. We could attain no further data on this patient, whose case was lost due to lack of additional follow-up. Summary. PCH, once thought to be a rare disease and mostly associated with congenital syphilis, is now recognized as one of the most common causes of acute transient hemolytic anemia in young children after a respiratory viral infection. The key diagnostic test is Donat-Landsteiner test. Thank you. Thank you.